Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today we are going to discuss about spinal cord injury. This is very high yield topic and it's very very important topic in our in medical field. Okay, so here in this video I'm mostly focusing on anatomy and pathophysiology and classification and some how we can diagnose the spinal cord injury, and because we have some types and some classification and we have some syndromes also. So everything we are going to cover in this video and with management also. Okay, so first, what is meant by spinal cord injury? The spinal cord injury means it's a trauma or insult to the spinal cord causing temporary or permanent motor, sensory, autonomic dysfunction below the level of the injury. Okay, so if anyone asking what is meant by spinal cord injury, that time we can easily tell like, okay, damage to the spinal cord that results in loss of function, because spinal cord is very important for our motor system, motor and sensory and autonomic nervous system. Okay, so for sensations and for doing the for doing motor functions and sensory functions and autonomic functions, everything is based on spinal cord. If anything happen with spinal cord, then it will cause loss of functions. Okay, so causes, what are the things can cause spinal cord injury means, first one, trauma. If we are dividing to traumatic and non-traumatic, in traumatic we can see like motor vehicle accident and like falls and gunshot can cause the spinal cord injury, like traumatic spinal cord injury. In non-traumatic you can see like tumor, because the tumor is compressing the spinal cord, then it can lead to loss of function. Okay, and some infections also, and some ischemic attack, and and some like multiple sclerosis also can cause this type of spinal cord injuries. Okay, so now we are going to discuss very important, that is anatomy. Okay, the spinal cord. First of all, what is spinal cord? If you are seeing this image, this is the main spinal cord. I am drawing in this vertebral column. If you are seeing this first image, you can appreciate that. Okay, the spinal cord is a cylindrical structure of nervous system. It extends from medulla oblongata and it will end till L1 and L2 in adults. Okay, the spinal cord is a like first one, cylindrical structure. It extends from medulla oblongata, okay, to L1 and L2 in mostly we can see in adults. Okay, what are the main functions the spinal cord will do means, it's like motor control and sensory input, and we will get some reflexes and some autonomic regulation. Okay, this autonomic regulation and sensory input and motor control, everything we will discuss when we are when I am going to teach nervous system, that time I will cover this everything. Okay, so in anatomy mostly we have to focus in from foramen magnum, from medulla oblongata, then we can see some foramen magnum. From that foramen magnum, that spinal cord will pass and it will end till L1 to L2 in adults. Okay, then what about children means, L3 in children's. Okay, now what's the main height of this spinal cord means, in males we can see 45 centimeters and in female like 43 centimeters. Okay, and this spinal cord we can divide into two parts. How? In Just see this image. This is very important image. If you are seeing this image, in the spinal cord, the spinal cord is divided into some segments, and or you can tell that is vertebra. Okay, in the spinal cord segments, here you can see C1 to C7, and here you can see T1 to T12, and here L1 to L5, and here sacrum. That sacrum is total, we have 5 bones, but it's fused with coccyx, and total that S1 to S5 it will fuse. Okay, fused bones. So here this cervical C1 to C7 we call that is cervical spine. Okay, and this thoracic spine means T1 to T12, that vertebrae we can see. In lumbar region L1 to L5, and in sacrum total it's fused bone and it's attached with some coccyx, that is 1. Okay, so here main thing is from C1 to C4 to T1 we can see brachial plexus. This brachial plexus is very important for our extremities, upper extremities, because from here only we will get sensation and motor function for your shoulder and elbow and wrist and everything. Okay, if any problem happen in this area like cord compression or cervical spondylosis or cervical radiculopathy, then the pain is totally radiates to your fingers and the tip of the fingers based on that nerve compression, based on that vertebra compression. Okay, based on that nerve compression. Okay, so we have to understand first brachial plexus and everything. This brachial plexus I'm going to discuss in our first aid series, so we can learn from there. Okay, next one we can see lumbosacral nerves. It will comes from L1 to, that means here to L3, L1 to S3. We call that is lumbar or sacral, and we can tell lumbosacral plexus. Okay, it's very important because in the lumbar sacral plexus, why we told means some patient we can see sciatica. Sciatica means that the pain is radiating from like lower back to, it will radiate to total tip of the great toe. Okay, based on that nerve compression we can see the that radiating pain. Okay, so we have to understand the dermatomes and myotomes. Based on that we can diagnose in which level that patient have compression. Okay, so next, now when we are going to the, if I cut the spinal cord like this, okay, I am cutting the spinal cord like this and I am seeing from the top. If I am seeing from the top, I will see this type of image. If I am cutting this spinal cord like this, and if I am seeing from the top this spinal cord, then I am going to see this type of image. Okay, this is the cross section of spinal cord. Okay, in this cross section of spinal cord, first of all I am focusing on gray matter. Gray matter means this black one, gray color. Okay, this inside this butterfly shape, this thing we call gray matter. In this gray matter will be like H shaped. Here mostly we can see cell bodies of motor neurons and it relay some neurons. In this gray matter, if you are seeing dorsal horn, that means this back side of the horn, this dorsal horn will take sensory input. If you are seeing ventral horn, that means this front one. Okay, ventral means anterior, dorsal means posterior. Okay, in ventral horn we can see motor related things. In lateral horn, that means this one, this lateral horn will help for autonomics. In autonomics mostly like T1 to L2. Okay, now this is, I already mentioned this sensory. Okay, this is relay neurons, that means that sensory input it will take and it will it will do integration, then after it will pass to brain, then after from brain it's passing that motor neuron. Okay, if you know the that tracks, how that the ascending tract and descending tract, how it will work, then if you know these things properly, then you can easily understand these things. Okay, next, white matter. If you are seeing white matter, that means this one, this total white color, we call that is white matter. This white matter mostly contains of bundles of myelinated axons, because this myelinated axons can pass because of the saltatory movement, that now impulses will pass very fast. Okay, so in white matter we can see two types of tracks. In white matter we can see two types of tracts. That one, yeah, first one ascending tract and second one descending tract. Okay, in ascending tract we can see some spinothalamic tracts and dorsal column tracts, and in descending tract, very important, that is the corticospinal tract. If any injury happen in these tracts, that movement, that functions, everything will collapse. Okay, so that's why we are learning these things. Now we don't have space here. Okay, now blood supply of the spinal cord. I don't have space, that's why I'm writing here. Blood supply of spinal cord. If you are seeing blood supply of spinal cord, we can see anterior spinal artery. It will provide anterior 2/3 part of the spinal cord. Next, posterior spinal artery. It will provide for posterior 1/3 of the spinal cord. Next, radicular arteries. It's inclined artery of Adam Kiewicz. Okay, it's like we can see that artery passing like T9 to L2. Okay, this is the blood supply of spinal cord. Now main part I already mentioned. Now we are going to discuss about tracts. I already told that spinal cord, that total in white matter we can see two types of tracts, that is ascending tract and descending tract. When it's coming to ascending tract, you have to focus on sensory, because ascending tract mostly function is sensory. So if you feel any sensation like pain or heat or any vibration, or because of pain, like that nociceptors will pass some impulse, and ascending tract will take over of that impulse, and it will take to the brain. The brain will get integration, then after the descending tract will take over and it will do motor function. Okay, so this ascending tract will be sensory and the descending tract will be motor. Okay, now first ascending tract. In ascending tract, first one we can see in ascending tract, first we can see dorsal column. First we can see dorsal column. This dorsal column is mostly helps for fine touch and vibration, proprioception, and it crosses in medulla. It crosses in medulla. Okay, so dorsal column carries vibration, conscious, proprioception, and 2 points of discrimination, and here this dorsal column will cross in medulla like this. Okay, next, spinothalamic tract. This spinothalamic tract we can see lateral and anterior. This spinal thalamic tract is main important is it transmits pressure, crude touch, pain and temperature and sensation, and this main crosses in spinal cord. It crosses at spinal cord. This thing is very important. Because of this thing only we can understand the pathology of the spinal cord we can easily understand that how much problem we have in that spinal cord. Okay, it can come back to normal life, or it will total that lower part, and because of that tract injuries we can understand how that patient will feel and what are the things we can see, and everything we can easily observe. Okay, next, spinocerebellar tract. If you are seeing spinocerebellar tract, it transmits unconscious proprioceptive information from voluntary musculature. Here, that means this spinocerebellar tract, its main function is unconscious proprioception. Okay, so in this spinothalamic tract we can see some mesencephalic tract. This it will do pain suppression, and spinotactile tract it will do reflexive eye and head movements towards site of painful stimuli, and spinoreticular tract like attention to painful stimulus. Okay, so when it's coming to this is we discussed ascending tract. Now we are going to discuss about descending tract. I forget, I don't have image, so I am writing here. Yeah, now descending tracts. I already told descending tracts means motor. In this descending tracts, first one we can see lateral corticospinal tract. Lateral corticospinal tract. This mostly, what's the main function means, it will do the voluntary movements. Voluntary movement, and same to same like if this tracts will crosses at medulla, same to same like anterior, same to same like in ascending tract like dorsal column tract. Okay, and second one, anterior corticospinal tract. This anterior corticospinal tract is the main function is it will help to do trunk movement. Okay, it will help to do trunk movement. Now, yeah, and we have some Golgi tendon organ. This Golgi tendon organ is main function is for muscle. Okay, now classification of the spinal cord injury. If you are seeing the classification of spinal cord injury means mostly it's like by neurological deficit, because that is main for function like motor, sensory and autonomic functions. Main thing is spinal cord. If any damage or any injury happen to spinal cord means we can see some neurologic deficit. In neurologic deficit, first one we can divide into two types, two parts like complete spinal cord injury and incomplete spinal cord injury. In complete spinal cord injury, you can see no motor and sensory, and below level of the inclining below level of the spinal cord. Okay, and including like S1 and S5. That means no sensory or motor below level of the injury. Okay, next one, incomplete spinal cord injury. Incomplete spinal cord injury means it's like partial preservation, it's like below the injury. Okay, so after that below the injury we can't see any function in that body. Okay, so next, level of injury. In level of injury, okay, I think I didn't mention here, so I am writing rightly. In level of injury you can, yeah, now level of injury. In level of injury we can divide this thing into two pieces. First one, tetraplegia. This tetraplegia where we can see, and another one paraplegia. Paraplegia means off side of the body, like hemiplegia, off side of the body will be like paralysis. Okay, tetraplegia means total paralysis. So where we can see this tetraplegia means if any patient got cervical cord injury, if any patient got cervical cord injury, we can say that patient have tetraplegia. If any patient have paraplegia means we have to think about thoracic and lumbar injury. Okay, this thing is very important, that's why I am mentioning here. Okay, next, in classification mostly we have one ASIA impairment scale. ASIA means American Spinal Injury Association. They gave one scale, so we are following that scale. Okay, so here A means it's like complete. A means complete and no sensory and motor below, like no motor, no sensory and no sacral sparing. Second one, like B means like ASIA, it's like one type of scale. Based on that scale we can easily understand that injury, how much injury happened. In B means incomplete. In this incomplete we can see sensory, we can see some sensory but no motor. Okay, so and third one like C. In C we can see incomplete. In this incomplete mostly 50% of muscle, okay, less than grade 3, can't raise arms or leg off bed. That means it's like incomplete, and we can see motor functions but less than 50% and greater than equal to like muscle manual muscle test. In manual muscle test we can see like greater than equal to grade 3. Okay, next D. In D it's like incomplete and 50% of muscle like more than grade 3 can raise arms or legs off the bed. Okay, that means it will be like motor, it's like greater than equal to 50% and greater than equal to grade 3. Then it's coming to E, last one, that is normal. Motor and sensory functions are normal. Okay, so in neurological level of injury, if you are seeing means it's like lowest segment with intact motor, like grade greater than equal to 3 and sensory 2/2 functions. Okay, so next, by level of injury, like based on level we can see some clinical features. If any injury happen in cervical area, then we can see the patient this type of things like quadriplegia and tetraplegia we already discussed. Next, if any patient have injury in thoracic area, then it's a thoracic spinal cord, then that patient we can see paraplegia. If any patient have injury in lumbar region, then we can see lower paraplegia and bowel and bladder problems. That means the patient can't sense and motor functions, autonomic functions totally absent. Okay, in sacral area, if any injury happen in sacral area, then bowel, bladder and sexual dysfunction we can see in this type of injuries. Okay, next, by mechanism of injury we can think. Second one, hyperflexion. In hyperflexion means like motor vehicle accidents we can see this type of mechanism of injury, that is hyperflexion. Next one, hyperextension, like full fall on chin. If any like in neck have like if any car accidents happens means in that car accidents like dashboard injury, that time because of neck hyperextension we can see this type of injuries. Next one, compression, like if any person falling from height, then we can see compression type of mechanism of injury. Next, rotation and penetrating means if any person have stab or gunshot. Okay, next, pathophysiology. In pathophysiology we can divide the spinal cord injury into two types of injuries, primary and secondary. In primary injury, that patient getting direct trauma like neuronal and vascular damage we can say in this spinal cord injuries. In secondary, ischemia or edema or inflammation, it worsens injury over hours, then after days it will be go to worst prognosis. Okay. Next, clinical features. In clinical features, mostly we can see some like motor loss, like flaccid and spastic paralysis, and sensory loss like dermatomes are dependent, and autonomic dysfunctions like hypotension, bradycardia like neurogenic shock, urinary retention in sacral region, any patient have any injury, then you can see urinary retention, bowel incontinence and sexual dysfunction. Okay. And now we came to very important part. If you are planning to write an USMLE or FMGE or NEET PG or like some type of medical exams, then mostly in spinal cord injury that that examiner will focus on these syndromes. Okay. So it's very exam favorite things, important syndromes we are going to discuss. First one, anterior cord syndrome. In anterior cord syndrome we can see like motor, pain and temperature loss, and dorsal column spared, and sometimes we can see like infection of anterior spinal artery. Okay. So motor plus pain and temperature loss and dorsal column spared, and we can see some infection of anterior spinal artery. Second one, central cord syndrome. In central cord syndrome we can see weakness greater than in upper limb. Mostly in upper extremities we can see mostly motor loss and compared with lower extremities, and usually in elder people we can see this thing. Okay. Older adults, and because of hyperextension injury we can see this type of central cord syndrome. Third one, Brown-Séquard syndrome. Brown-Séquard syndrome is because hemisection of cord or ipsilateral motor plus DCML loss and contralateral pain temperature loss we can see in this Brown-Séquard syndrome. Okay. And mostly proprioception loss also we can see. Next one, posterior cord syndrome. This posterior cord syndrome is very rare and it's mostly loss of vibration and proprioception we can see in this posterior cord syndrome. Next one, conus medullaris versus cauda equina. It's like we can see mostly lower motor neuron signs like saddle anesthesia. This saddle anesthesia means, how I can tell, yeah, this saddle anesthesia means if you are doing horse riding, because of too much horse riding, that jumping, that our medial thigh and our genital part and anal area and buttocks part, and this everything will get some type of numbness. That numbness thing we call that is saddle anesthesia, and we can see some bladder bowel dysfunction. And for cauda equina and these things we have to, this is very surgical emergency things. Okay. Yeah, this saddle anesthesia mostly we can see like cauda equina syndrome, and sometimes mostly I observed this thing in spinal listhesis, retrograde spinal listhesis. If any patient have this type of pathological conditions like spinolisthesis, retrograde spinal listhesis, so I saw this type of saddle anesthesia clinical features in that patient. Okay. Next one, management. Next one, diagnosis. In diagnosis we can follow ABCDE trauma protocols like airway, breathing, circulation and any disability and any exposure, everything we have to check. Then after we can do neurological examination like based on American Spinal Cord Injury Association scoring scale, impairment scale. Next we can do imaging like X-ray. In X-ray mostly we can have to focus on lateral view and anterior posterior view and odontoid view, and CT scan. In CT scan we can, so if you are suspecting any fractures then we can do CT scan. Next we can do MRI for if you are suspecting any spinal cord injury or ligament injury or soft tissue injuries, or bulbocavernous reflex also we can check early recovery sign. Okay. Now in management, I already mentioned in management we can think about, first we have to stabilize the patient. Okay. So how? First of all you have to check airway, airway, breathing and circulation with every time cervical spine protection. So we have to use cervical collar okay, because if you are moving already that patient, for example, patient fall from height, and we saw that patient in our emergency department. If you are moving that cervical spine, that patient can get that spinal cord injury will go to severe conditions. That's why we don't want to move that thing. That's why we have to give cervical spine protection. Then immobilization, we have to do immobilization with cervical collar, a long roll, and we have to maintain blood pressure, like mean arterial pressure like 85 to 90 mmHg for 7 days at least, because we can with this thing we can prevent secondary ischemic conditions. Okay, next one, we have to avoid hypotension and hypoxia, so we can provide some oxygen. Okay, and we can give high dose of steroids, and methylprednisolone is the controversial and no longer routine used. Okay, next we can do like Foley's catheter for urinary retention, and we have to start deep venous thrombosis like prophylaxis. We can start low molecular weight heparin, and we have to monitor for neurogenic shock like hypotension, bradycardia and vasopressors. Okay, next one, in surgical indications, like if patient have unable fractures or cord compression. Okay, so if any patient have cord compression, then we have to do surgical decompression, especially in incomplete injuries. Okay, then we have to stabilize the patient, like, and we can do the progressive neurological deficit, and we have to do decompression plus stabilization like posterior and anterior, based on posterior and anterior approach. Okay, based on surgical surgeon prefer, and we have to do stabilization with rods, and we can use some screws. Next, rehabilitation. In rehabilitation, next one, rehabilitation. In rehabilitation, we can do like physical therapy and occupational therapy. Okay, next, when it's coming to complications, in complications mostly, every time this spinal cord injury is the like life threatening conditions, and it can cause like paralysis things, so that's why always we have to focus on these things. So now in complications, mostly in complications we can see first one, respiratory failure. In respiratory failure, if any patient have that injury in especially C3, C4, C5, then the patient will get respiratory failure. Next one, autonomic dysreflexia. Autonomic dysreflexia like T62 or above the T6 injury, then we can see sudden hypertension or headache and bradycardia, and it will remove triggers. Removes triggers means like full bladder or constipation complications we can see. Next one, if patient have spinal cord injury and we are not moving that patient, then the patient can develop the pressure ulcers, because always we are keeping that patient in same position, like in supine position, then that because of that body weight, it will cause that perfusion of the blood. Because of that perfusion of the blood, that part will get ischemia, and then after it can leads to ulcers. Okay, and we can see urinary tract infections, complications like complication and spasticity, and sometimes heterotrophic ossification. And we can see neurogenic shock, and because of no movements it can develop the DVT and pulmonary embolism also. Okay, next we can see the rehabilitation and long-term care. How we can do rehabilitation and long-term care means, first one with physiotherapy. Why? Physiotherapy will prevent the contractures, and it will maintain the strength, and we can provide some occupational therapy and bowel and bladder training, and if you are moving always that that patient position, then we can decrease the pressure sore ulcer prevention, and orthotic devices and social support like social workers. Okay, now mostly this for the spinal cord injuries. Now we are going to discuss about prognosis. In prognosis, if patient like complete spinal cord injury and incomplete spinal cord injury, in complete spinal cord injury, very less chance to get recovery and to get like a normal like before life. Okay, it's very difficult. Incomplete spinal cord injury, we can bring it to better outcome, but not like same like normal people. Okay, next one, this most motor recovery occurs, motor function recovery occurs in first 6 months. Okay, now how we can differentiate that neurogenic and versus spinal shock. Mostly like, okay, first I am going to discuss about spinal shock and neurogenic shock. In spinal shock, if like sudden spinal cord injury or in pathophysical temporary loss of reflexes, in blood like blood pressure and heart rate will be like variable. In reflexes we can see absent and are initially resolution, absent initially, and in resolution hours to weeks we can see. In neurogenic shock, mostly it's caused by injury above the level of the T6, and we can see loss of sympathetic tone, and the blood pressure and heart rate will decrease, and the reflexes will be present, and the resolution will be like hours to day. Okay, so how we can prevent this thing? We can prevent this thing, we can while driving wear seat belts and helmets, and fall prevention, and always patient education. Okay, so these are the things will come in spinal cord injury. Mostly I covered everything. So if you have any doubts, you can ask me in comment section. So like, share and subscribe. We will meet in our next video. Take care. Bye bye.